a lot of interesting things happening, and I want to cover some of those things over the next 60 minutes. First of all, this is where I work at the South Australian Health and Medical Research Institute. It's a very exciting modern building right next to the new hospital as well. And these are my disclosures and a disclaimer for this presentation. So when we think about the overall response to tyrosine kinase inhibitor therapy in chronic myeloid leukemia, there's a lot of heterogeneity or variability in response. We have about 10% who don't respond adequately to therapy. They don't achieve a meaningful molecular response. We have a further 10% who have a response and then lose that response. So about 20% where we struggle with resistance. And it's from this 20% that we still have about 10% of our patients who die of a CML-related death. That can be either due to blast crisis, or it can be due to the complications of an allogeneic stem cell transplant. We then have about 30% who achieve a good response, but not a deep response. And many of these patients don't seem to improve as you follow them over the years. They do achieve major molecular response in many cases, but they don't get to the point where you can consider them eligible for treatment-free remission. So that's about half the patients. The other half do achieve a deep molecular response. And certainly in Adelaide, 2006, we've considered the patients potentially eligible for treatment-free remission, so that after about 5 or 6 years, if they maintain that deep molecular response, if they wish to attempt treatment-free remission, we stop therapy. And as you know, in about half the patients, you see a very rapid loss of molecular response off therapy, and they go back on therapy and achieve a deep response and remain on therapy thereafter. And the other half who remain negative over the long term. So if you look at the overall picture, we're really only achieving the truly optimal response in about 25, perhaps 30% of our patients. So we still have a long way to go. And I think we can do a lot better, particularly now that we have more and more, I think, third generation and beyond tyrosine kinase inhibitors that offer us a better chance of achieving a deep response and finally achieving treatment-free remission. So what are our goals when we look at a patient at diagnosis? What do we want to achieve for that patient? Well, looking at the goals, I think that there are 3 general goals. First of all, we want to achieve a normal lifespan for that person, if at all possible. And to achieve that, we clearly need to avoid transformation to beyond chronic phase. But importantly, we also need to avoid organ damage. And that would be either lung or cardiac damage that can be due to the drugs that we use. So the other things that we need to do to achieve a normal lifespan, but perhaps equally important, we want to achieve normal quality of life. And to achieve that, we clearly need to avoid any organ damage that might impact on a patient's capacity to have a normal life, but also minimize the day-to-day side effects that may not shorten life, but certainly take away some of the quality of that life, such as edema, muscle cramps, nausea, all these things that can make it a struggle for a patient to tolerate their tyrosine kinase inhibitor therapy. The third goal that I have for my patients is ultimately to achieve treatment-free remission, which gives them the potential to have a normal lifespan and a normal quality of life, and ultimately, effectively, a cure. And to achieve that, we know that the 2 critical parameters are the rapid initial molecular response, and I'll show you the data that demonstrates that, and secondly, you need to have a sustained deep molecular response. And if you can achieve both of those, you have a reasonable chance of achieving treatment-free remission. I want to just briefly mention 3, I think, quite exciting developments in the frontline scenario. The first is the potential for low-dose dasatinib to be an effective frontline therapy. The second is the demonstrated superiority of nilotinib to imatinib used in an optimized way, which we'll discuss in a moment. And the third is the exciting data that's now emerging using asciminib as a monotherapy or potentially as a combination therapy in the front line. And this is data that's come from the MD Anderson, where we look at the molecular results of 3 different dasatinib trials. The first one shown in the first column is the decision trial, looking at the dasatinib 100 milligram arm, 100 milligrams per day, compared to the 2 phase 2 MD Anderson studies, the earlier one using 100 milligrams of dasatinib and the more recent one where they used 50 milligrams per day of dasatinib. And what you'll notice if you look at the 2-year data and perhaps even at the 5-year data is, as you might expect, the molecular responses are better in the phase 2 study than in the multi-center phase 3 study, where you look in yellow. These are the patients who achieve MR 4.5 at 5 years on 100 milligrams of dasatinib, and those that achieve major molecular response in blue. So 85% achieving major molecular response and 67% achieving MR 4.5. But notice that in the cohort of patients who received the lower dose of 50 milligrams a day, the results were potentially even better. Now, why would that be? Why would a lower dose achieve better responses? I think the most likely reason would be that using a lower dose is associated with better tolerance and therefore better capacity to use the drug on an everyday basis without any interruptions due to toxicity. But I think we need to be cautious about these results. And here I'm comparing the results of the dasatinib 50 milligrams per day study from the MD Anderson, shown on the left side, to a recent Indian cohort study using 50 milligrams of generic dasatinib, where a similar number of patients were looked at, assessed in terms of their response at 12 months. And while the level of MR2, which is less than 1% BCR-ABL on the international scale, was fairly similar across both studies, there were significantly more patients achieving major molecular response in the US study compared to the Indian study. And I would suggest that the likely reason for that is seen below, where you look at the SoCal scores in these 2 studies. In the US study, which is typical for high-income countries, very few patients have high SoCal scores, only 9%. If you look at the Indian cohort, over a third of the patients have a high SoCal score, and very few patients have a low SoCal score. So I think we need to be cautious at the moment, and until we see larger studies and randomized studies, perhaps the conclusion would be that the reduced dose of 50 milligrams per day looks to be a very promising dose for patients with a low SoCal score, but you need to be more cautious about patients with high SoCal score. I now want to briefly mention a really interesting and important study that's come from the Italian group, and this is recently presented at the European Hematology Association meeting. It was a randomized study comparing frontline nilotinib, 300 milligrams twice daily, to imatinib, 400 milligrams a day, with early switch to nilotinib if the patients did not achieve an optimal response. And this is the design of the study, simply to show you that the patients, large number of patients, 450 newly diagnosed patients, were randomized to either nilotinib, 300 milligrams twice daily, or imatinib with switch across to nilotinib if they didn't maintain or achieve a optimal molecular response. This is very much in line with the TIDEL-2 trial that we performed in Australia some years ago and showed very promising results. So this is the first time that there's been a formal testing of these 2 approaches head to head. And I just show this slide to demonstrate that there's good balance between the two arms, as you might expect in a randomized trial. And here's the overall outcome. So the primary endpoint was MR 4.5, so a deep molecular response at 24 months. And what you see is significantly more patients achieving this response if they had frontline nilotinib compared to if they had frontline imatinib. So that's a very clear advantage. But what's fascinating is when you look at the dividing these patients up according to their ELTS score. So this is shown here. So up until recently, we've used the SoCal score because it's simple to calculate, and it does identify patients with low, intermediate, and high-risk CML. But in fact, the ELTS score does a better job at predicting leukemia-related survival. And in fact, it uses exactly the same parameters as the SoCal score. So the spleen size, the platelets size, the platelet number, the blast percentage, and the age. But it uses slightly different formula to SoCal. And so what you see here is quite a dramatic finding. The patients who have a low SoCal score, there's a very substantial advantage to receiving nilotinib frontline. 43% achieving MR 4.5 versus just 23%. But for the patients with intermediate and high ELTS scores, there's really very little evidence of an advantage, at least in terms of achieving a deep response when using nilotinib rather than imatinib. So I think this is quite an unexpected finding and really quite provocative. Now, I do want to focus on this really exciting new agent, asciminib. It's a so-called STAMP inhibitor, which stands for specifically targeting the BCR-ABL myristoyl pocket, STAMP inhibitor. And the reason it's so unusual is because its mechanism of action is distinct from all the other tyrosine kinase inhibitors. All the other ones are so-called ATP competitive. They bind in this kinase domain and they compete with ATP for that binding. By contrast, asciminib binds in this unique myristoyl pocket, which as far as we know is not present in any other kinase. So asciminib has this great advantage that it has specificity for BCR-ABL and ABL, whereas every other tyrosine kinase inhibitor we use in CML will also have activity against many other kinases. So that's its first advantage. Its second advantage is that it can block the activity of BCR-ABL with great potency. And its third advantage is that it can still bind when there is a ATP competitive tyrosine kinase inhibitor bound in the ATP binding site. So you can have the potential advantage of combination therapy. So it's a very exciting new drug with lots of potential uses. And before I deal with the third line use, which is where it is now licensed in many countries, and I understand will be licensed in Taiwan quite shortly, I want to deal with a phase 2 study that we're conducting in Australia, where we're using asciminib as a frontline therapy. And this is a study that my colleague David Jung has been leading, involving 15 centres around Australia and New Zealand. And this is the design of the study. It looks rather complicated, but I'll take you through it slowly. So it's basically patients are eligible if they have chronic phase CML at diagnosis, over 18, good organ function, good performance status, and they start on asciminib 40 milligrams twice daily. In fact, more recently, we've been persuaded that 80 milligrams once a day is equivalent to 40 milligrams twice a day. So patients now receive 80 milligrams once a day. And patients remain on that standard dose as long as they maintain so-called optimal molecular response, less than 10% at 3 months, less than 1% at 6 months, less than 0.1% at 12 months, and less than 0.01% at 18 months. If they have levels slightly above this, you're allowed to double the dose to 80 milligrams BD. But if patients actually have treatment failure, that is BCR-ABL greater than 10% at 3 or 6 months, or greater than 1% at 12 or 18 months, you can actually add a ATP competitive drug, either nilotinib, dasatinib, or imatinib to the asciminib to see if you can achieve better response. Now, so far at this early stage, we can report that thrombocytopenia, neutropenia, anemia of significance, grade 3 or 4, occur at similar rates as what we've seen in other trials with the other agents. So it's not higher, but it's not lower. We do see a significant number of patients with grade 3 or 4 lipase elevation, but it very rarely leads to pancreatitis. Only one patient out of 100 in the in this ASCEND study actually developed pancreatitis, but you do quite commonly see elevated lipase, and I think in most cases it can very rapidly resolve on its own, and it shouldn't really be a cause of great concern. We also see very low levels of grade 3, 4 other adverse events, as you see here. So in summary, it's a very well-tolerated drug in the frontline setting. Most of the patients will tell you that they don't really know that they're taking an active drug. And here is the response that we reported at the American Society of Hematology meeting last year, and we'll be updating this at the meeting this year. So at 3 months, already we have 92% of the patients achieving early molecular response. That is less than 10% BCR-ABL. And quite remarkably, 84% are already achieving MR2, less than 1%, and almost half have already achieved major molecular response by 3 months. How does this compare to our previous study, the TIDEL-2 study, which I mentioned earlier, which was imatinib-based, but using 600 milligrams of imatinib? Well, you can see that it's similar in terms of the rate of EMR. It's looking superior for MR2, and it's looking vastly superior for major molecular response at this early time point. Now, when we compare the experience of the ASCEND study using asciminib frontline, compare the 3-month response across other studies where we have the data. We have the TIDEL study I've already mentioned. We also have the high-dose imatinib study from the MD Anderson. We have the frontline ponatinib study, so-called EPIC, that was run as a multi-center study until the vascular toxicity was realized and the study was closed. We also have a smallish MD Anderson study of ponatinib up front. And then we have Decision, INEST-ND, and Before, where imatinib was randomized to either dasatinib, nilotinib, or bosutinib. And what you see is the rates of early molecular response. Well, asciminib looks very, very good, but it looks about the same as nilotinib and ponatinib. But when you get to deeper responses, you start to see that the only thing that's really comparable is ponatinib. And of course, we wouldn't contemplate using ponatinib in the front line today because of its toxicity. And then when you get to MR4, it even looks to be superior across the whole range of other therapies. So it's exciting, but it's early days. We do have a little bit of follow-up data so far that I can present, and that shows that the 3-month, 6-month, and 12-month results, there's a steady improvement in major molecular response in MR4 and in MR4.5. Now, looking at the halving time. Halving time is a concept that we introduced some years ago. It's really it's based on the level of BCR-ABL at this time of starting and the level after 3 months. And based on those two figures, you can calculate how rapidly the transcript halved, and by inference, how rapidly the leukemia halved in number. And we see that with imatinib 400 milligrams, the median value in a big cohort of patients studied in Australia was about 18 days. The halving time came down significantly with a higher dose of imatinib, and even further down with frontline nilotinib or dasatinib, 2 studies we've run in Australia recently. But it looks to be at least as good, perhaps even better, with the asciminib monotherapy. So it's certainly a very potent therapy. And this is worth remembering when we talk about treatment-free remission in a moment. So the conclusions from the ASCEND study at this early stage is with a median follow-up of 11 months, asciminib demonstrated promising efficacy and very favorable tolerability. Most patients achieved early molecular response, nearly half achieved major molecular response, and there were many already achieving MR4 or better, supporting this approach as a strategy for maximizing treatment-free remission. The safety results are very encouraging as well. And when this slide was made, there were no vascular occlusive events. We've so far only had one patient with a vascular occlusive event out of 100, with a median follow-up now out to 26 months. So it looks to be very, very promising. Now, I want to briefly talk about treatment-free remission. This is a big focus of ours in Adelaide, and I think it's really where we should be putting a lot of our research efforts. Now, clearly, we'd all agree that achieving treatment-free remission is the optimal outcome, but the frustrating thing is that it's only achieved by a minority of patients, and when it is attempted, there's still a rather high failure rate of about 50%. And also, it's frustrating that for many patients, you require many years of kinase inhibitor therapy before you can actually get eligibility. So in terms of our current challenges, we need to be sure that we can select the patients who are eligible and appropriate to attempt treatment-free remission, and we need to make sure that we safely manage that process so that we don't do any harm. And over the next 5 to 10 years, we should be aiming to increase the number of patients who are eligible for treatment-free remission. We would like to minimize the number of patients who have molecular relapse and decrease the burden of monitoring, because at the moment we recommend monthly monitoring out to 6 months, and then 2 monthly until 12 months, and then 3 monthly. But we think that's probably more than we need to do. And finally, we need to decrease the duration of TKI therapy before patients are eligible, because I think patients would be much happier if they could get to the point of being eligible after 2 or 3 years rather than having to wait 5, 6 or more years. Now, there have been many studies of discontinuation. Our own study, the Twister study, was started in 2006, the same year as the STIM-1 study from France, and they both had similar conclusions about a 40% rate of maintaining treatment-free remission. And many studies since then have confirmed those early findings. In fact, the rate of success is looking closer to 50% in many of those studies, now with over 2,000 patients studied. An important observation is that patients who lose their response and go back on therapy achieve major molecular response again very rapidly. So half of them have achieved it within 6 weeks, and virtually all patients have achieved it within 18 weeks. And in fact, if you look at the rate of re-achieving MR 4.5, 95% of patients do achieve MR 4.5 again, just 5% don't reach that same level of depth. So what are the best predictors of treatment-free remission? Well, in our experience, the duration of therapy and the duration of deep molecular response remains the best predictor, and the one that most people should be able to calculate in their patients. We've demonstrated that the halving time is a very important predictor of success. Not everybody has access to that calculation. And interestingly, the transcript type. So you'll find that about half of your patients have the E13A2 transcript, and half have the slightly longer E14A2 transcript. And it is clear now that patients with the longer transcript, the E14A2 transcript, have about a 10% better chance of treatment-free remission for reasons we don't understand at all. There's also a lot of data that immune measures can predict the patients who will be successful, but that's a complex area that at the moment is not ready for day-to-day practice. One of the consistent findings, and this is just one of the studies that's demonstrated this, is that the duration of the deep response does correspond to the likelihood of success. This is data from the MD Anderson, where patients who had MR4, so less than 0.01%, for more than 5 years, when they stopped, had a success rate of 88%, whereas patients who'd had at least 2 years of MR4, but no more than 5 years, the success rate was only 66%. Does suggest that there is a value to being patient and waiting till your patient has a sustained deep molecular response. Now, I want to show you briefly the data that we have on halving time. And this is the first evidence that we had. When we measured the halving time, and remember that this is the halving time that the patients had in their first 3 months of therapy. So it may well have been 6, 7, or 8 years before they actually stopped therapy. And all of these patients were eligible to stop therapy. They all had at least 2 years of MR 4.5. But the patients who were successful at stopping, that's those so-called, they sustained their treatment-free remission, all had quite short halving times, around 10 days, whereas the patients who were unsuccessful tended to have significantly longer halving times. Even though they were eligible for treatment-free remission when they stopped, they still had long halving times in the first 3 months of therapy, and that corresponded to a much higher risk of molecular relapse. And looking at it in another way, if you divide halving times into quartiles, short half times being less than 9 days, long halving times being greater than 21 days. If you look at those patients on the red curve, even though they'd had 2 years of MR 4.5, they were clearly eligible. When they stopped therapy, they had a very poor chance of success, whereas the patients who had a short halving time in that first quartile had an almost 80% chance of success. So we think it's a very valuable measure. But you have to be confident you can measure it accurately because some of the PCR techniques do not allow you to calculate without accuracy the halving time. And when we look at the European Leukemia Net recommendations for treatment-free remission, they've got a nice table in the paper from 2020, first author Andreas Hockhaus, in which they lay out minimal criteria and optimal criteria. And they're always worth referring to when you're deciding whether you feel it's safe to stop your patient. But also remember these top lines here, which suggest the patient must be in first chronic phase. Patient must be motivated and capable of having a structured communication with their physician on a regular basis when they have their monthly PCR tests. They have to have access to high quality, internationally standardized RQ-PCR with a rapid turnaround. It's no good doing a test every month if the result doesn't come back for 3 months. And patients must agree to undergo frequent monitoring after stopping. And if all those criteria apply, then you can look at the specific criteria related to the duration of therapy and the duration of deep response. I won't go through the details, but they're all clearly demonstrated in the table. So what are the frequently asked questions that I get when I talk about treatment-free remission with my patients? Well, if they've been on Facebook with other CML patients, they'll ask me about withdrawal syndrome. And I'll tell them that it occurs in about 30% of patients. They will get malaise, fatigue, muscle pains, joint pains, and it can be upsetting. They can actually feel worse than when they're on drug, but it's very much a self-limiting syndrome. In nearly all patients, it's disappeared by 12 months. It doesn't leave any long-term damage. And in most patients, it can be managed with an analgesic or very rarely with a brief course of steroid. There's a risk that by stopping now, you may be stopping prematurely, and that if you waited another year or two, you would be successful, whereas if you stop today, you won't be. And it's very hard to answer that question, but that's clearly a risk. There is that small risk that if you have to restart, you won't re-establish the deep molecular response. It's only about 5%. There have been at least 3 cases of blast crisis in patients who have been either in treatment-free remission or restarted drug after attempting treatment-free remission. But put that in context, that's 3 out of over 3,000 patients who've been followed. So the risk at this stage is around about 1 in 1,000, probably about the same risk that is present for patients who remain on their tyrosine kinase inhibitor. But of course, the discussion with the patient needs to be very clear that what we're doing here, we talk about the risk of stopping, you need to consider the risk of not stopping. And we know that even with the most benign drug, imatinib, there's a risk of progressive renal impairment if you remain on drug long term. So it's always a balance of risk between stopping and continuing. And in terms of what's the best time, what's the best strategy, well, clearly there is a benefit to waiting longer, but the benefit to waiting an extra year is actually quite marginal. The benefit to having the addition of interferon, it's now been studied in many contexts, either having the interferon as part of the initial therapy or stopping the TKI and going on to interferon for a set period. There seems to be quite a limited benefit. And so most people feel that interferon has a limited role to play in the setting of treatment-free remission. But there certainly is interesting data suggesting that if you halve the dose for 12 months, it doesn't seem to impair the rate of success when you stop after that halving of a dose. In fact, the data from Destiny would suggest that the success rate might be even a bit higher. So that's something that some patients would feel more comfortable about, halving the dose for 12 months before stopping rather than going straight to stopping. So briefly, I want to mention how I select frontline therapy. And this is very much a personal opinion. I try and make it a shared decision with the patient. So they need to know all the facts, including the reality that one of my aims of therapy is treatment-free remission. And I'm trying to assess three key variables. What is their ELTS score? What are their comorbidities? Importantly, what's their cardiovascular risk profile? And I'll try to formally assess that, usually using the Framingham risk score. And finally, how strong is their motivation to treatment-free remission? Clearly, with a young patient, it's usually very strong. In a patient over the age of 70, it may be very little. And this is what I set out as my suggested therapy 10 years ago when I presented the ASH education talk. I suggested that you can divide patients up according to their risk score. At this stage, it was a SOCAR risk score on the y-axis. And on the x-axis, you could look at their priority for treatment-free remission. And I suggested that the patients who had either a high priority for treatment-free remission or a high SOCAR score, I would tend to prefer to use a more potent drug, nilotinib or dasatinib. And for the other patients, I would use imatinib. Now, it's somewhat different today based on some of that data that I've already presented today, and that's shown here, where I would still use the risk score, but this time I would use the ELTS risk score for the y-axis, and I would divide on the x-axis into 4 different categories. For the patients who have a very high priority for treatment-free remission, particularly young women who want to have a family as soon as possible, but also for young, fit, healthy males and females have a low cardiovascular risk, I would tend to prefer nilotinib. It's a highly potent drug, and it's probably, I think, the best drug to achieve reliably a very deep molecular response. For the patients who are less than 60, where I've got more concern about cardiovascular toxicity, that I have an intermediate or high risk cardiovascular score, I would tend to prefer dasatinib, and I would tend to use the higher dose, the standard dose, of 100, except perhaps for the low ELTS risk score, where we've got pretty reassuring data now. That's a very effective strategy, 50 milligrams a day. Patients over 60, I'm starting to get concerned about the pleural effusions that you see on 100 milligrams a day, and I would tend to prefer using dasatinib 50 milligrams per day for all of those different ELTS scores. And for patients over 75, I would probably still use dasatinib 50 milligrams per day for the high ELTS group, but for the intermediate and low risk, I would tend to prefer imatinib as probably the safest drug of all, because we still see a problem with pleural effusions in those older patients using any dose of dasatinib. Now, clearly, that's a generalization. You do need to consider specific toxicities. For instance, if a patient had a history of pleural effusions or pulmonary arterial hypertension, I would certainly avoid dasatinib. Patients with QT prolongation, I would avoid nilotinib. I won't go through the whole list, but you need to use a more refined consideration when you have your patient in front of you. If you have a patient with pancreatitis, I would tend to avoid nilotinib and ponatinib and potentially asciminib, but that's not really established yet. And of course, another thing that I think it's worth always looking at, and this is a nice summary from JCO a few years ago, all of the cardiovascular assessments that you should consider in your patients, depending on which drug you are choosing. I won't detail all of those in the interest of time. Okay, one important observation that has come from many studies, but this is one example. This is a Canadian study looking at why patients switch from first line to second line, from second line to third line. And the conclusion here is very clearly that the predominant reason for patients switching is intolerance rather than resistance. You can see there the ratio of patients who switched on their first switch was 1.2 in favor of intolerance. For their second switch, it was 3.1 in favor of intolerance, 3 times as many patients switching for intolerance. And for a third switch, it was 2.5. In other words, the vast majority of patients who are switching therapy are switching for intolerance. That's important because, as I'll show in a moment, asciminib is very much a drug which has its place in patients who have intolerance. So I need to briefly mention, I'm sure you've seen this study before, but it's worth reminding you before we go into our discussion, this very important study where asciminib was compared to bosutinib in the third line or later line setting. This was so-called ASSEMBLE study. Now, this was a 2-to-1 randomization of asciminib compared to bosutinib, asciminib monotherapy, 40 milligrams twice daily, and eligible patients were patients who had chronic phase CML, previously treated with at least 2 tyrosine kinase inhibitors, and had failure or intolerance to their most recent TKI. They weren't allowed to have T315I mutation or V299L mutation because they would not be eligible for bosutinib, so they couldn't be randomized. So that was the study. And here is the 96-week data. Some of the most important observation is shown here. How many patients are still on study? Well, on the asciminib arm, over half are still on drug. On the bosutinib arm, less than 20% are on drug. Incredible difference. And why was that the case? Here are the reasons for discontinuation. About 24% discontinued for lack of efficacy on asciminib, but it was 35% for bosutinib. But in greater contrast, only 7% came off the asciminib because of toxicity compared to 25% on bosutinib. And this is similar to our frontline asciminib study where only 6% have now come off therapy with a follow-up of almost 2 years, clearly showing that asciminib is a well-tolerated drug that the vast majority of patients will be able to maintain. And here's the key data. These are the rates of major molecular response in the 2 arms at 24, 48, and 96 weeks, where you can see clear superiority shown in green for the asciminib arm compared to the bosutinib arm. Now at 96 weeks, 38% versus 16% at 96 weeks, clearly showing the superiority of asciminib. And that also follows, if you look at the MR2 rate, which may be a target for your patients in third line, where the superiority is even more evident at all 3 time points. It's interesting to note that there were mutations seen in patients who lost response to asciminib. Let's leave aside the bosutinib for a moment, just focus on the asciminib patients. So in 39 patients who lost response, there was a mutation detected in just over half. And in a quarter of them, 25%, it was a new mutation. You can see here some of those new mutations were in the myristoyl pocket where we predicted we'd see mutations to asciminib. But surprisingly, there were also mutations seen in the ATP binding site, 244, 355, 359, 315. So in fact, you can see mutations occurring not just at the myristoyl pocket, but in the ATP binding site. So it's not as though asciminib, you can completely ignore the possibility of resistance due to ATP binding mutations. Having said that, we're not seeing this in the frontline setting. So it's probably the case that these are being selected by their previous therapy and then are coming through on asciminib therapy. In terms of adverse events, you see in green the asciminib events, and in blue the bosutinib events, and the dark green, the dark blue are all grade. The light green, light blue are grade 3, 4. And what you'll notice is, as you expect, very high rates of GI toxicity and liver toxicity with bosutinib, very low rates, certainly with grade 3, 4 with asciminib. The only thing we're seeing with asciminib here is thrombocytopenia and neutropenia at similar rates to what we see with bosutinib. Now, one thing we're watching closely is the arterial occlusive events seen with asciminib, and you'll see that the thing to look at closely is the arterial occlusive events per 100 patient years, and does seem to be slightly higher with asciminib than with bosutinib. Bosutinib is recognized to be associated with relatively low rates of occlusive events, and so you do see a possible signal here. 3 versus 1.4. We'll compare these numbers to ponatinib in a moment. So the conclusions from ASSEMBLE are that ASSEMBLE is the first randomized controlled phase 3 trial comparing asciminib to another drug, and that with over 2 years of follow-up, asciminib has demonstrated superior efficacy and better safety and tolerability compared to bosutinib. And that the quality of life was something we haven't really mentioned, but quality of life looked remarkably good on the asciminib arm as measured by formal assessment. And with later follow-up, we're seeing continuing improvement in response in the asciminib patients. We have a little bit of data about using asciminib in the setting of T315I, a mutation which we know is leads to resistance to all of the first and second generation drugs. And in the past, we've had to use ponatinib for this mutation. But there's promising data using asciminib at the higher dose. This is 5 times higher dose than we use for the other settings. But we're seeing very promising rates of major molecular response. Clearly, the rates are better for patients who have not received ponatinib. As you'd guess, patients who had already received ponatinib and had failed that therapy have lower rates of success, but still it suggests this is a very promising approach in the setting of T315I, but you have to use a higher dose. So that's important to remember. Now, I need to mention the OPTIC study. It's a very important study that has just come along, which gives us a bit more insight into how to use ponatinib safely if we're able to use ponatinib. It's a very cleverly designed study where patients who are resistant to 2 or more drugs, not intolerant, but just resistant, were able to go on to 3 randomized arms, either ponatinib at the standard dose, 45 milligrams a day, or 30 milligrams a day, or 15 milligrams a day. And if you received the higher 2 doses, once you achieved MR2, that's less than 1%, you went down to 15 milligrams per day. The rationale was once they achieved that response, they would hopefully be able to be maintained on a lower dose that would reduce their vascular toxicity. And the questions that were being asked were, could you maintain their response on a lower dose? And would this strategy lead to lower rates of cardiovascular toxicity? Well, the conclusions now with 36 months of follow-up are pretty clear. And that is if you use 45 milligrams as your frontline dose, but reduce to 15 as soon as you achieve MR2, you do achieve superior rates of MR2. That's less than 1% BCR-ABL. You see that here. It's very clear cut. But it's actually important to look at the sub-analysis. That's shown here. And this is where you see comparisons of the 45 milligrams, the 30 milligrams, or the 15 milligram doses. And you see that using the 45 milligrams up front is very clearly superior for patients with the 315I mutation, not so clearly superior for patients with other mutations or with no mutations. And it's also clearly superior for patients who came onto the study with very high levels of resistance. They hadn't even achieved a molecular response at all, or even a cytogenetic response. This superiority of 45 milligrams a day was very clear. It wasn't so clear for patients who had partial responses to previous therapy. So the conclusion is that you do need to use 45 milligrams a day for patients with T315I, or for patients with very resistant disease, but you can probably use modified doses for other patients. But in any case, you do need to reduce the dose once they achieve MR2. But it's important to know what happened to the patients when they did reduce their dose. So here's the actual data for the patients who went from 45 down to 15. Let's focus on this rather than the other cohort. Patients who reduced their dose from 45 to 15 because they achieved less than 1% or MR2. There were 56 patients who achieved this level, and 15, or around about a third, who lost that response when they reduced their dose. So 12 of those patients re-escalated. 3 didn't re-escalate, presumably because they didn't want to, or the investigator didn't want to. And 9 of those 12 did then achieve the deep response again, or at least MR2, but 3 didn't. So it's not completely fail-proof, this approach, but on the whole, it is an effective approach for many patients. So this is a comparison of the arterial occlusive events from the PACE study, comparing that to this newer study, the OPTIC study, with the 3 arms, the 45 going down to 15, 30 going down to 15, or 15 going on continuously. And you see the rate of arterial occlusive events per 100 patient years can be substantially reduced from the 15 seen in the PACE study down to around about 10, and that's halved on the 30 milligrams and further reduced on 15 milligrams. But we know this is a fairly ineffective dose for most approaches. That compares to asciminib, where the rate is 3, and bosutinib, where it's 1.4. So it looks like asciminib at the standard dose is about equivalent to using 15 milligrams per day of ponatinib. Now, there has recently been an interesting attempt to compare asciminib to ponatinib and to other drugs in a third-line setting by using this approach of matched, adjusted, indirect comparisons. So in this approach, you have to match patients head-to-head so that you can get rid of some of the biasing because of the way patients were enrolled to the studies. And I don't want to go through this in detail, simply to say that when you actually compared asciminib to ponatinib and you excluded patients who had had, in the asciminib cohort, who had had ponatinib prior to going on to the asciminib, because that's an unfair comparison, there seemed to be a superiority with the asciminib in terms of the molecular response, perhaps not so clear-cut in terms of the cytogenetic response. There's now an accumulation of real-world data using asciminib in the third-line setting, small study from Australia and many other countries, suggesting that the rates of major molecular response overall are very encouraging, sort of inconsistent with the ASSEMBLE study. And they're also quite promising in many patients who had failed ponatinib, where you see pretty good rates of response, and also for patients, now 84 patients who'd had T315I mutations, where you see quite promising responses. So the data is now accumulating that in the third line, this is an effective drug. So how do I approach a patient with tyrosine kinase inhibitor resistance or apparent resistance? Well, the first thing to say is if a patient has an increasing level of BCR-ABL, so you feel that they're losing response, the first thing I ask is whether they're actually taking their drug, because poor drug adherence is still a common cause for a rising level of BCR-ABL. And if that's the cause, then patient education and counseling, close monitoring, and optimized symptom control are very important. If you're confident the patient is taking their drug, then you're dealing with tyrosine kinase inhibitor resistance. You need to determine 4 things. What is the nature of their kinase domain mutations, if they have any, because that can guide your next line therapy? Do they have clonal evolution? So if they have a BCR-ABL level greater than 1%, it's very likely if you do a bone marrow, you'll be able to get a meaningful karyotype to measure whether they have additional changes besides the Philadelphia chromosome. What are their comorbidities? That'll determine which drugs you might prefer, and what's their vascular risk profile. And once you have that, in many cases, the choice will be between ponatinib and asciminib, and the dose will also be determined by these variables. So I would say that if the reason the patient is going on to next line therapy is intolerance, I would, in nearly every case, prefer asciminib to any other drug. And the data is very, very encouraging for asciminib in this setting. And I have some patients who have been resistant to several lines of intolerant to 3 or 4 lines of tyrosine kinase inhibitor therapy, but they've tolerated asciminib very well. So it's a clear-cut recommendation. I also recommend asciminib for patients who have treatment failure, but they still have responsive disease. The simple way to determine that is, do they have a level of BCR less than 10%? Because in that setting, the asciminib data looks quite comparable to the ponatinib data, but of course, asciminib has the advantage of better safety and lower cardiovascular toxicity. Now, for the patients with high-level resistance, I would tend to prefer ponatinib in most cases, or patients who haven't achieved a major cytogenetic response or a greater than 10%, that would usually define patients who have pan resistance. For patients with specific mutations, I think asciminib will have a role, but it would depend on the context of the patient, whether you'd prefer asciminib or ponatinib. For other mutations, you need to know whether asciminib is active. And for most patients with a kinase domain mutation, except for the case of compound mutations, you can be confident ponatinib will be active. So you need to know the profile of mutations to make that decision. So what I try and do is, on the x-axis, I assess the level of resistance of the patient. Is it low-level resistance? They're not achieving their optimal response. Is it high-level resistance or refractory disease? And then the second thing I determine is, what is their cardiovascular risk profile? And by doing that, at this end of the scale, I'm talking about patients with no cardiovascular risk. At this end, they have a high cardiovascular risk. So the patients with very high-level resistance, I would tend to prefer ponatinib, except for the patients with significantly higher cardiovascular risk. For the patients who are partially responsive, I would tend to prefer ponatinib for the patients who have low cardiovascular risk, but I would have a low threshold for preferring asciminib if the patients have intermediate or high high cardiovascular risk scores. And clearly, if they have intolerance or failure to achieve optimal molecular response, I would prefer asciminib in every case. And this is by far the commonest reason we're switching to a third-line therapy today. So in conclusion, in the front line, it's important that you share decision-making with your patient, if at all possible, and you need to balance questions of efficacy with questions of tolerability. Asciminib monotherapy looks very promising, but we'll need to wait for the randomized studies to make clear conclusions about where it sits in terms of its advantages over imatinib or second-generation drugs. Treatment-free remission should now be a mainstream goal of therapy. The duration of kinase inhibitor therapy, the duration of deep molecular response are clearly critical to that determination. You really can't contemplate it if you're not able to do frequent monitoring with a rapid turnaround. It's not safe for the patient if you don't get your results for 3 months. They may have hematological relapse before you recognize the fact that they're losing response. In terms of third-line management, asciminib has been demonstrated to be superior to bosutinib, and ponatinib can be used in a less toxic way using the optic approach where it's appropriate to use ponatinib. The choice between asciminib and ponatinib is often a difficult choice because we don't have a randomized study to help us, and it needs to be based on the vascular risk and the resistance profile, as I've already explained. Now, low-dose dasatinib looks promising, but pleural effusions are still common in the elderly, so there's still a role for imatinib in those patients, particularly in the intermediate and low-risk setting. Interestingly, nilotinib has clear advantages to imatinib in the low-risk group. So no longer do I say that a low-risk patient is better treated with imatinib. In fact, there's a clear advantage to using a more potent drug in terms of achieving a deep response. And asciminib monotherapy is well tolerated and promising. And I think as we go forward, we may well see that will become our treatment of preference in the front line. I want to thank the collaborators right around Australia for the data represented, particularly my team in Adelaide. I'll show that again, and particularly Sue Branford, who provides a world-class molecular laboratory for us to work on. And I also want to mention that in 3 weeks' time, I'm climbing to Annapurna Base Camp with 25 colleagues, including some patients with CML, to raise money for the International CML Foundation to improve our capacity to educate, to train, to disseminate molecular monitoring in low and middle income countries, and to improve our capacity to do worldwide research in terms of our Genomic Alliance and our TFR Alliance. So if you'd like to donate to my climb, you're able to you'd get that QR code. Very, very happy to boost my motivation to do this climb. It's a 6-day climb, getting to 4,200 meters, which is quite high, and all for the sake of improving our research and treatment for CML patients worldwide. And on that note, I will stop and thank you very much for your attention.
Thank you so much for Professor Hughes' very comprehensive, informative, and educational talk. There's several questions come from online. I will ask the first question for Professor Hughes is, when encountering TKI intolerance in later lines, what is the recommended minimal dose for TKI respectively? How long will you consider switching to another TKI if the intolerance persists?
Okay, I think our approach is changing as we get more and better choices of tyrosine kinase inhibitors. When we only had imatinib, we had to just push on at lower doses if necessary. If patients developed, a severe rash, we had to desensitize them. But of course, once we got second generation drugs, we didn't have to worry about that. And we could increasingly switch the patient to the drug that they tolerated better. So I would always prefer switching to another drug than using a therapy that I thought was used at too low a dose. So for instance, I'm uncomfortable to use doses less than 50 milligrams of dasatinib, unless it's the only drug that I can really use for that patient. And now that we have, in many cases, the option of asciminib, I would tend to go to asciminib rather than lowering the dose below 50 milligrams. And likewise with imatinib, I would be comfortable with 400 milligrams or even 300 milligrams. I would be very reluctant to use lower doses than that when I have the possibility to switch to asciminib, which I know is a very safe and well-tolerated drug. So I think today, as the availability of asciminib becomes more widely disseminated, it's going to become a preferred therapy rather than going to doses that we don't really feel comfortable are therapeutic.
So, with intolerance, you do not reduce the dose first. You change it to other TKI, right?
Yes, I mean, there is always a place for reduced dose. Today I never use nilotinib at 400 milligrams twice daily, or very, very rarely, because of the significantly higher risk of cardiovascular events. So if I have a patient who's on that dose because they've been on it for a long period or on a trial, I will always reduce them to a lower dose. And in many cases, I will consider switching them to either dasatinib or increasingly today, switching them to asciminib, because I'm worried about that increasing risk of cardiovascular events over the longer term. So that's my approach.
So, Professor Hughes, could I ask a question about the How about the low dose of the dasatinib? We heard some experts say we can use dasatinib as low to 20 milligram a day. So how about you? Would you comment about the dose of the dasatinib?
Yeah, I do think that dasatinib can be used at a lower dose. I tend to use it at 50 milligrams a day in my patients over the age of 60 in most cases, because the risk of pleural effusions is so high with 100 milligrams, and the data from the MD Anderson study and also from our own study using drug levels to modify the dose demonstrated that for most patients, 50 milligrams is an adequate dose. For my younger patients, I would always start with 100 milligrams, but once they achieve a good response, I would, in many cases, prefer to lower their dose to 50 milligrams a day. And that, I think, is very well tolerated. In the vast majority of patients will maintain their response on that lower dose.
Okay, another
And
question.
we saw, sorry, we saw some literature mention about the dasatinib can be induced the proteinuria. So if the patient have the CKD, would you suggest to use low dose of the dasatinib or switch to another 9 of the TKI for his or their CML?
Yeah, if I've really got any concerns about comorbidities, including renal impairment or certainly any pulmonary concerns, I would prefer to use 50 milligrams a day. I think that's a safer dose. Using lower doses than that, I'm quite uncomfortable about, and I have done it in the past when I had no other choice. But today, I would tend to prefer to switch that patient to asciminib if I can.
Okay, thank you.
Another question. In asciminib trial, what is your recommendation about this?
Yeah, we haven't seen significant rates of venous thrombosis in either the ASCEMBL trial or the phase 1 trial or in the ASCEND trial. I think it's probably just a coincidence. This patient made a quick recovery and has continued on therapy, as far as I remember. So I think it's a rare event and probably not related. Well, obviously, we'll watch this closely, but at this stage, 1 in 100 doesn't concern me greatly. So 1 event in 100 patients doesn't concern me greatly.
Thank you. Additional question. How do you think to try a different drug like asciminib might work better than ATP competitive TKI such as ponatinib for pan-resistant patient?
Yeah, I don't know. I'm not that convinced. I mean, I think asciminib's advantage is that it's highly potent and it's very, very well tolerated because of its specificity. But for the patient with highly resistant disease, it's unlikely that simply hitting BCR-ABL potently on its own is going to be sufficient to achieve good response. It may be in that setting, a combination approach may be effective, but I think monotherapy in ASCEMBL, the advantage of asciminib was the fact that it could be used continuously and at pretty much full dose. It wasn't because it was achieving response where it had never been achieved with, high dose ponatinib. I don't think you'd have very much chance of achieving a good response in a patient who had frank resistance to ponatinib. I mean, I think I'd try it if I had to, but I think it's a low likelihood that it would be effective. That's not the reason that I think asciminib is a breakthrough drug. I think it's a breakthrough drug because it's incredibly well tolerated and it's highly potent, but it's not the answer for the patients who've got high-grade, highly resistant disease.
Thank you. Next question. When and how will you discuss TFR treatment goal with patient? What is the percentage of patient you will try for TFR?
Yeah, this is an important question because it's quite controversial. Some clinicians believe that it's too complicated to discuss something that's probably going to be 5 to 10 years down the road, discussing that with them at diagnosis. And it also might send the wrong message. You're talking about stopping therapy when the message should be about taking therapy. But I think it is important as the initial discussion because for many patients, it's their interest and attitude towards treatment-free remission that influences which drug I will select. So it's hard to have an open discussion with the patient if you're not being fully revealing about the reasons why you want to choose one drug over another. So, if for a patient with low ELTS risk disease, may ask you, why not just have imatinib since the risk of my disease transforming is incredibly low with any drug. And the reason I want to use a more potent drug is because they have a fantastic chance of achieving treatment-free remission. So if I don't discuss that with the patient, I can't make a shared decision about why I've chosen to use a potentially more toxic drug because I believe that it gives them a better chance of treatment-free remission. The other important reason that I think discussing treatment-free remission from the start is because it changes patients' attitude to their therapy. Mm-hmm. This is not a drug that I take for the rest of my life, like my blood pressure tablets, and I can take it or leave it depending on how I feel. This is a drug that I'm taking to achieve a goal that is deep molecular response, sustained for at least a number of years, where I might be able to stop therapy for good. And that sort of motivation, I think, changes the way patients take their drug and makes them much more adherent to their drug therapy. So that's why I discuss it with them right at the start.
Yeah. This slide shows our experience of TFR. From the beginning, 533 patients have been treated for imatinib for 5 years, and the second generation TKI for 4 years. They are candidates to have deep molecular response after follow-up. Of this patient, majority received imatinib. So overall, 34 patients fulfill the eligible criteria for TFR. But for this patient, we only have 43 patients who agree for stop TKI. Another 57 continue to TKI. I hope in Taiwan, because our criteria for stop TKI is very strict, we need to achieve MR 4.5, even undetectable. At that time, we encourage patients.
Very good.
Maybe we show this data to the patient, and all the patients, and all the relapsed patients achieve deep molecular again for the 8 patients. So maybe use this data, we may provide the patient more confidence to stop.
Yeah, absolutely.
Okay.
Absolutely. Yeah, it's interesting. So you're I didn't hear all of that, but I think you're saying that a number of patients don't agree to stop even when they're eligible because they have concerns about the safety of stopping. Is that right?
Yeah. Yes.
Yeah.
I think, I think it's maybe
really refuse to stop. So maybe they may be concerned
Professor
about the
Chen.
relapse disease progression. Actually, no disease progression in the published paper or limited experience.
Yeah. Yeah. So we find that about 90% of the patients who are eligible to stop do stop. They might wait a year or two beyond when they are first eligible. That's fine, but the vast majority want to stop, and I think it's because the way we present it, it's not, do you want to take this risk? Do you want to take this leap into the unknown? It's all about there's a risk involved in trying to stop, but there's a risk involved in continuing your drug. It has toxicity. So at some point, that risk balance goes in favor of stopping. But I think that conversation helps a lot of patients decide that, yeah, this is not just let's not rock the boat, is what we say. Let's not rock the boat. But they understand that continuing the drug is also has risk.
Yeah.
And so it's a matter of balancing up that risk. So that's why I think we get about 90% of our patients who are eligible to actually stop, to actually attempt stopping.
Yeah, we are trying our best to encourage the patient to.
Well, I'm sure if you show them your data, that should encourage them a lot.
Thank you.
Yeah, Professor Xi and Professor Xu could be the so low percentage of patients in Taiwan to join the TFR program. It could be come from the because in Taiwan the national insurance reimbursement all kind this kind of TKI for the patient. So the patient don't not pay anything for his treatment. So it may be a reason some patients have low motivation to stop the medication.
Yeah. Yeah. That's, I mean, it's the same in Australia. The patients don't have to pay anything, or they do, but it's a very small amount for their drug. It's a small amount. So that's not a motivation for stopping. The motivation for stopping is when we explain the long-term toxicity, particularly patients on second-generation drugs, but even imatinib. You see that rate of renal impairment goes up over time, and that can't be a good thing for long-term well-being and survival. So I think these are things that we discuss, and that generally is persuasive.
Thank you.
So about the question of having time, there's a question asking about what are possible factors to affect having time of the TKI treatment. And I also had the question about are you use having time in Australia for routine care in the CML patient in the initial diagnosis?
Yeah, well, we certainly do in Adelaide. I don't think it's widely disseminated at this stage. One of the problems with halving time is that most people use a PCR technique where ABL is the control gene, and if you have a control gene, it compresses the whole scale, so you don't actually get an accurate halving time, and that's a problem that we're trying to deal with. We're currently determining whether you can use the gene expert machine. Do you have gene expert machines in Taiwan? The Cepheid, the gene expert machine, or not? It's a way of measuring the. No, okay. Oh, okay, well, that's not very relevant to you then. But it depends on what your control gene is. If it's anything besides ABL, you can calculate an accurate halving time. But unfortunately, most people in the world use ABL.
Okay.
Thank you. Another question regarding re-challenging patients with the TKI therapy, they experience a relapse following TFR. What are your thoughts on the decision of whether to resume treatment with the same TKI or switch to another TKI in order to achieve the next the
Yeah.
Deep molecular response. Does this choice have an impact on the time it takes to regain DMR?
That's a really good question. It's an important question because increasingly, we have a big cohort of patients who've tried and not succeeded. And the question is, what do you do with those patients? Most of them will say to you they want to try again. Some will say, well, that's it. I'm just going to take this drug the rest of my life and not bother. But most of them have an interest in a second attempt. So we know from the Canadian study that if you just switch to a more potent drug and try again in 2 years' time, which is what they did in Canada, the success rate was very, very low, like 10% or 20%. So simply using a more potent drug, but only waiting a short time is not a very good strategy. What we tend to do when patients lose response, we put them back on the same drug initially because we know that they tolerated that and we know that they achieved their response with that drug. And also, they've probably got a few of those tablets in their drawer, in their cupboard, so they can restart very easily. But of course, at their first visit, once they've achieved at least a major molecular response, we then will discuss with them, is it this the best choice to keep going, or should we try a different drug? And often if the first drug was imatinib, they would consider using the lotinib or dasatinib on the second occasion. Even so, we would still wait 4 or 5 years of deep molecular response before a second attempt. And by doing that, so far we're seeing a pretty good success rate, about 50% out of about 20 patients so far. But we wait about 4 years at least, 4 to 5 years of deep molecular response a second time. And I'm not sure whether it matters whether they're on a more potent drug the second time or not. But it's certainly, it's not sufficient just to put them on a more potent drug and think you can get away with stopping in a couple more and 2 more years. You need to wait.
Thank you. Another question is, in poor responder, if no ABL kinase mutation or additional cytogenetic abnormality are detected, do you perform additional gene mutation analysis to detect GSA, XS01, RUNX1, TP53, and how this data guide your further therapy.
Yeah, no, it's a really good question. I'm hoping in the future we will use all those things as a guide as to which drug to use next. But at the moment, we're still in the phase of accumulating data. What do these additional genomic events mean? What do they mean a diagnosis? What do they mean when patients develop resistance? And what do they mean in patients with progression to acute phase disease? At the moment, we're just acquiring data. So we can't make any specific recommendation. So I don't recommend those things to be done as part of routine practice. But if you want to be involved in the International CML Foundation Genomic Alliance, we're trying to get all of that data from around the world so we can see whether, for instance, ASXL1 mutation correlates with a poor outcome in different contexts. So at this stage, we need more research data before we can make that a mainstream approach.
So for this patient, do you think stem cell transplantation is an option for treatment?
So this is the question: how do you effectively manage pan-TKI-induced hemotoxicity? Hematotoxicity? Would transplantation be a viable option? Is this the question?
No, additional genetic, another.
Oh, I haven't got that question in front of me. If the patient has additional cytogenetic abnormalities, that would be an indication that the disease is high risk. And if they're a young patient, I would think very seriously about the potential for an allogeneic stem cell transplant. For patients who are not eligible, it simply means that you need to use a highly potent drug, and I'll be more inclined to use ponatinib if it was appropriate.
Thank you.
I have a question for Professor Shields. For the patient tried the TFR, you say have the 3 cases have breast crisis. So if the patient have the chance to be tried TFR, how could we to explain about the risk of the breast crisis or the concern about the breast crisis for patient?
Well, the data is now in. We've looked at over 3,000 patients, and there's only been 3 cases of blast crisis. And I think if you looked at 3,000 patients who were on TKI therapy, you might expect to see 2 or 3 cases of blast crisis. So I don't think the risk is higher for patients who are in treatment-free remission. I think being off your drug is probably makes the risk lower. So I don't believe it's a risk that you need to be concerned about, but I will explain it to patients so they understand that the risk is extremely low.
Thank you.
Next question: how do you effectively manage pan-TKI-induced hematotoxicity? Would the transplantation be a viable option?
Yeah, these are some of the most challenging patients we see. Patients who not only don't respond well, but develop severe cytopenias, which also means you struggle to give them effective drug. What I would say is that we tend to get more aggressive as their disease becomes more advanced and more refractory. So the patient at diagnosis, we tend to be very cautious about thrombocytopenia and neutropenia, and we'd often stop for a period and then restart. But if a patient has failed several drugs and looks to be moving towards more aggressive disease, we start to get more aggressive in that we would continue to give them treatment even if their platelet count was 30 or even 25. We might even consider giving them platelet transfusions. We'd continue giving them treatment even if their neutrophils fell. We can consider giving them a GCSF,